So I'm going to talk about advances in global cancer care. So let me start my talk by telling you a story about a woman whom I met almost 20 years back, nearly 20 years back. She was about 56 years old. You can see she had this horrible bleeding mass. Eventually, her sister-in-law noted she was bleeding, and she came to a doctor. She was not ignorant. She had insurance. But the reason why she delayed her care was because she was taking care of her family member. We just had a session before. They talked about the importance of taking care of ourselves. She, like any other woman, not just in US or India, any other woman across the world who puts their family ahead of their own health. So luckily, she had what we call as an EGFR overexpression or HER2 overexpression, and that had a new treatment at that time. And of course, it's not new now. Trastuzumab-containing regimen, she had a complete response, and she lived cancer-free for the next 10 years or so, eventually died from a pneumonia. So she's not alone in this story with the cancer diagnosis. More than 20 million people would get a diagnosis of cancer this year. And about half of those diagnoses, 10 million, will happen here in Asia. So you can see the red box. In our neighborhood, nearly 10 million diagnoses of cancer diagnosis. So 2/3 of new cancer diagnosis in the world is happening in low and middle-income countries. So India ranks third after US and China in number of cancer incidences. And we'll have more than 2 million cancer diagnoses. You can see a steady rise. I know in the previous panel discussion, people talked about a huge rise in non-communicable diseases, almost 19 million to 30 million cancer diagnoses. The staggering number all the policymakers and healthcare leaders has to prepare for. So, and of course, when there is increase in number of incidents, there will be definitely increase in number of mortality. There's almost 65% increase in number of mortality in the next 20 years globally from cancer diagnosis. Of course, more than half will happen here, from almost 10 million to 16 million. So I'm going to introduce you to another friend of mine, a patient of mine. She's one of our colleagues. She worked in the ICU. She was a nurse. By the time she came to me, she had extensive metastatic breast cancer, triple negative, and I'm sure those who are in the oncology field knows that in general, it's one of the most aggressive for breast cancer. And she came to me for a third opinion. By the time she had chemo, surgery, radiation, and almost third line of treatment. And even you don't need a radiologist to point that, and she had disease in the chest, which was invading the chest wall. And that time we talked about different treatment options, from potentially treating to focusing on supportive care or palliative care. So when a patient comes to see me in Cleveland, or for that matter, any place, I think any highly specialized places, one of the questions I always ask is what we can do beyond standard of care. If standard of care, they don't have to come to a big center like our centers, Cleveland Clinic. They can get that from anywhere. So I always encourage my trainees to look beyond the obvious. So we did genetic testing, germline testing, and of course genomic sequencing, and of course we look for clinical trials. That's what, in a kind of a big outline I always think about. So of course, germline testing, I put Angelina Jolie's picture there. When she came out and announced her bilateral mastectomy and oophorectomy after she was found to have a BRCA1 mutation, the impact, global impact was so much, which is a good thing, we started doing more germline testing. So she had triple negative breast cancer. She's 59 years old. And in patients with triple-negative breast cancer, they have a high chance of having a BRCA1 mutation. So she had a BRCA1 mutation, and that time the FDA hasn't approved a PARP inhibitor for this diagnosis, but we put her on a PARP inhibitor, and she had a complete response. And this is a picture from recently, a CT scan from recently. She's almost 10 years with no evidence of disease. So I talked about 2 patients. Both patients came with fairly advanced disease, but the better understanding of the biology of the disease, we were able to come up with treatments which can target that particular overexpression or a mutation or DNA repair pathway, and the patient could achieve a complete remission, which is considered as non-curable disease, and we are achieving a long-term survival. And she's actually a much better avid biker than me. She rides a bike to raise money for our cancer center. So these are the 5 major advances happening in the world of cancer care. I think we talked about almost all these things in the past few hours or so. We talked about targeted treatments, immunotherapy, which is revolutionizing cancer care, of course, genomic testing, and gene editing using CRISPR technology, and we had a whole session on AI, so I don't have to talk about that. So again, I'll highlight a few of these things. So targeted therapies, as I said before, in the 2 patients I used as an example, we have really moving away from the traditional cytotoxic agents, the chemotherapy agents. We can say the sledgehammer to really focusing on specific treatments which is based upon their mutations or changes within the genomic profile. We have a number of tyrosine kinase inhibitors, monoclonal antibodies, antibody-drug conjugates recently, and of course, bispecific antibodies. So this didn't happen overnight. The investment in the field of cancer really helped us to understand what's the biology of the disease that led to the development of some of this targeted treatment. Brian Drucker in the bottom of the picture, he's a professor at University of Oregon. We can almost say that he's the father of the targeted treatment when the first targeted treatment for chronic myeloid leukemia was approved, which is imatinib. But again, Brian Drucker didn't make it happen. The investment in the field of cancer over the past 50 years, Janet Rowley from University of Chicago, and actually scientists from University of Pennsylvania discovered some of the initial translocations that led to the discovery of a tyrosine kinase for chronic myeloid leukemia. I'm sure all of you are familiar with the story of Jimmy Carter. You're kind of seeing, I'm seeing so many Democratic presidents from years, right? Yeah. So Jimmy Carter, from his story of diagnosis of metastatic melanoma, so about 10 years back or so, he was diagnosed with metastatic melanoma to the brain. And he was treated with pembrolizumab, which is an immunotherapy, PD-1 blocker, and he had a complete remission. And recently, of course, he's at this point, he's older than 100, he's in hospice care, but he casted his vote for Kamala Harris. So immunotherapy, which is in development for the last many years, almost 100 years or so, Jim Allison and many scientists worked in this field. Dr. Allison received Nobel Prize in 2018 for his work. The field has moved substantially in this area. So from CAR-T to TILs, tumor-infiltrating lymphocytes, and PD-1 blockers. So this is, again, another fascinating field. In few minutes, actually, Sam Sandosh is going to talk about this in detail. He's much smarter than me in talking about this. So I always tell my trainees, completion of Human Genome Project is the moon landing of our time. It's really an amazing collaboration between 7 different countries, eventually led to the completion of the project in June 2000. You can see President Bill Clinton, another Democratic president, Bill Clinton announcing this at the White House with Craig Venter, who's, again, another fascinating personality, and then Francis Collins and Tony Blair on a video call. So this really helped us to understand what's the unique genetic makeup of tumor, between tumors, even individuals, and that's allowing us to identify mutations and developing targeted treatment. And another fascinating thing about genomic revolution is when this was completed to a genomic testing, a genomic sequencing in 2000, it cost about $100 million. And then now, it's down to less than $1,000. It's probably one of the fastest drop in cost of any testing. And I'm sure Sam may tell us he can do that much cheaper than $1,000 in India. So moving on, so CRISPR technology or gene editing. This is the most important biological advance since the discovery of structure of DNA by Watson and Crick in 1950s. This is amazing. Usually we say that our genetic code really define who we are. Now we are kind of saying we can challenge the nature or God, whomever, and edit the DNA and then change our fate. So, Emmanuel Charpentier from France and Jennifer Doudna from UC Berkeley received Nobel Prize for their work in 2020. So at this point, it's being used for thalassemia and sickle cell. Hopefully in the future, we'll have gene editing technologies for other common cancers, such as breast cancer and colon cancer. So when I was flying from Philadelphia, I was looking at the New York Times, and there was a front page news about this boy being wheeled out of the hospital after receiving and after completing the first gene therapy for sickle cell. I'm not going to talk about this. We had so many sessions on this thing, and I'm sure all of you know that. In 2024 was actually a fascinating Nobel Prize year. 5 people received Nobel Prize on AI, 2 in physics. Of course, Professor Hinton from University of Toronto, who can be considered as the father of AI. And then you can see that the gentleman so they received for physics. And Dennis Hassabis, I think one of the previous speakers talked about synthetic biology of protein synthesis or AlphaFold. Dennis Hassabis and his friends started the technology, and that really changing our understanding of protein structure. So these 2 teams received Nobel Prize for revolutionizing AI. So from my perspective, from oncology, this will change drug discovery, of course, care delivery, access and affordability of our drugs, in addition to how it's going to affect the synthetic biology. So we talked about a rapid rise in cancer incidence across the globe, particularly in our parts of the world, in Asia. And of course, we talked about all the advances happening all over the world. So when there's increase in cancer incidence and the advances are happening, in general, we can say more people are living with a diagnosis of cancer, or more people are living after a diagnosis of cancer than dying from cancer. So we have about 45 million cancer survivors in the world, and they face unique challenges. I really like this People magazine cover from 2009. Of course, Dr. Tharoor was here a few minutes back, and you see Kate and William in this picture. Of course, Kate just completed her treatment for cancer. And I really admire Ms. Ray for coming out and telling her story of survivorship in this magazine. So the good news is overall the mortality is coming down, there are more survivors, and we need to be prepared to face how do we treat the survivors with their chronic side effects. So that's my last slide, and thank you for the opportunity to talk about cancer care.